Good evening. First of all, I thank Dr. Chandramohan sir for giving me the most boring topic for the presentation. It's molecular classification, and I'm Dr. Anoop from RCC. So, when we discuss about the molecular pathogenesis of colorectal cancers, I think it is for when I discuss about the molecular classification of cancers, I think colorectal cancer is an ideal model for discussion. So we know that right from the how the small adenoma going to a large adenoma with an invasive component through different stages, and when we come about the molecular level of colorectal cancers, according to the Vogelstein model, we know that the germline or somatic mutations are required for the development of a malignant transformation of a tumor, and it is the multiple accumulation of multiple genetic mutation rather than the sequence which predict the biological behavior of the tumor. It is not this mutation, it's a multiple sequence, accumulation of multiple sequence which gives you this determine the biological behavior. So we know that the molecular pathways of colorectal cancer can be chromosomal instability pathway, or a DNA mismatch repair pathway, or a serrator polyp pathway, which is also called hypermethylation phenotype hyperplastic pathway. So what is this chromosomal instability pathway? You can get this instability in both hereditary cancers as well as the sporadic cancers. So you can see that the most common mutation you come across is the KRAS mutation, and you can get genomic features of chromosomal instability. Whereas in mismatch repair pathway, it is usually seen in hereditary cancers. You can get high MSI, and you can get mutation in the MLH1. Whereas going to the serrated pathway, this can occur both in the hereditary as well as in the sporadic. If it is a hereditary, you can get high MSI, and the most common mutation is BRAF mutation. And whereas if you are going for a sporadic one, you get high CMP and high incidence of BRAF mutation and low MSI. There is other pathway which is also called a hybrid pathway, where you get mixture of these pathways. Colorectal cancer subtyping consortium has unified the 6 independent molecular classification system in a single molecular classification system, which is called a consensus molecular subtypes based upon the genomic data. So they are one is CMS1, CMS2, CMS3, and CMS4. So what is CMS1? CMS1 is also called immune type, which comprises around 15%. I can see that the CMS1 precursor lesion is a serrated polyp, and it is most commonly seen in right-sided tumors. You get high BRAF 600E mutation rates, and there will be hypermethylation of CpG islands, and you can get mismatch repair and high MSI, and you can the tumor microenvironment is usually infiltrated with immunogenic lymphocytes. So this is basically immune activated stromal thing. So what is the clinical implication of this CMS1 tumors? So clinical implication is so most of the early stage tumors are CMS1 tumors, and you get high MSI in these tumors, and they usually have a favorable outcome when detected early, but after the dissemination, the prognosis is very bad. And due to the immunogenicity of this microenvironment, they are very sensitive to immunological agents, and you can go for immunomodulation using checkpoint inhibitors, and which is used in early clinical trials now. Coming to the CMS2, CMS2 is also called canonical type, which is the most common, and CRC in CMS2 arises from canonical adenocarcinoma to carcinoma sequence. You get high incidence of chromosomal instability, and you can get high number of copy number alterations and high number of copy number losses in T53 also. And CMS2 tumors are low mutation rate, and they have they have an activated BNT, cantonin, and MYC signal pathways. So what is the clinical implications of CMS2? 39% of the CMS2 tumors present with the stage 3 tumors, and they usually respond to chemotherapy, adjuvant chemotherapy. If you take the 5-year survival of CMS2 tumors, they have an excellent 5-year survival rate. And they are usually seen in the left-sided tumors, and they usually have a survival even after relapse. Then coming to the CMS3 type tumors, they are also called metabolic type, seen in 13% of the patients, and they have genomic features like that of CIN, and they also have they are also hypermutated. The most common mutation you come across is the KRAS mutation. The precursor lesion to the KRAS mutant CMS3 tumors are tubulovillous adenoma with serrated features. And they are basically immune mixed stroma, and they are usually seen in the right-sided tumors. So clinical implication is that if the patient is harboring a KRAS mutation, they may not respond to classical anti-EGFR agents. So CMS3 tumors who doesn't show any KRAS mutation may respond to KRAS inhibitors. And moreover, 3 to 5% of the patient will show HER2 positivity. So classically, HER2 mutations does not respond to anti-EGFR agents. So we can use combination of pan EGFR TKs along with this. Then EGFR antibody resistant CRC cell lines with KRAS mutations, a combination of pan RAF and MEK inhibitors used in clinical trials. Coming to the CMS4 tumors, they are also called mesenchymal type. It's usually seen in 25% of the patients. And the precursor lesion is a genetic signature consistent with the serrated pathway, and they extensively show low levels of hypermutation, and they usually MSS stable tumors, and they display mesenchymal phenotype, and the basic stroma is immunosuppressed, and clinical implication is they are usually diagnosed at advanced stage, and they have a very poor prognosis. If you take CMS for tumors, those patients who are going for adjuvant treatment, they show poor response to classical adjuvant chemotherapy. And if you're dealing with a metastatic disease, CMS tumors, they do not respond to anti-EGFR agents irrespective of the KRAS mutation. And in that cases, you can add anti-VEGF treatment, which may be useful. And there are agents which target the peritumor microenvironment, which is coming up. Thank you.
That was a crisp presentation. In terms of pure clinical practice, how do we apply this? It seems to be like a purely prognostic marker. If you know CMS 1, 2, 3, 4, that probably tells you whether this patient is going to do good or do bad. Does it help you with anything else? Only prognosis.
Yeah, it's only prognosis. The thing is that actually in our present clinical OPDs, actually we send a limited NGS in colorectal panel. So we may not get all the data from what we see with the molecular classification. It may change. I think it may change after maybe 5 years. We'll get some form of oncotype or something like that, where we can classify as CMS1, CMS2, and CMS3.
Oncotype colon is already there.
Yeah, colon is there. Coloprint is all there. Coloprint is all there. Yeah.
No, it has become molecular classification has been there for some time, but it's not used in day-to-day practice of. It's only prognostic, though. So maybe MRD is coming out the same way, but of course you can change the prognosis. So what I'm saying is, what would be classified as signet? What molecular classification would you put signet? Would you put mesenchymal or signet ring tumors?
Signet, I think, signet ring cell carcinoma. You don't specifically say that signet ring cell carcinomas are this type. There is no literature saying like.
Oh, there is no classification for that.
Yeah.
Oh, we have to make one then.
Anoop, you mentioned about the CMS1 type better prognosis.
Yeah.
Will it affect or will it influence the decision of neoadjuvant therapy?
Yeah, in the coming days, maybe because the patient with MSI high tumors, especially metastatic tumors, you can add immunological agents like pembrolizumab or dostarlimab in the metastatic setting. In the adjuvant setting, we have colon cancer, stage 4 colon cancer for MSI high patients. We usually do not give chemotherapy. We send the patient. If the patient show maybe theoretical, maybe showing higher risk features with MSI high, I don't know.
Any other questions from the floor? Thank you, Dr. Anoop.
Thank you.
Thank you so much.